Good morning, good afternoon, good evening. This is Dr. Anthony Chang. I'm the founder of AI Med. I'm really excited to bring you a webinar today on precision medicine and how do we find a needle in the haystack, so to speak. I think you've been hearing a lot about medical images, so it's really, I think, refreshing to take on another topic. And I have two wonderful guests today with us, Dr. Sibel Blau, who is from Northwest Medical, and she's an oncologist, and also a good friend, Dr. John Frownfelter from Jvion. So we're going to start with Sibel. So welcome, and thanks for arranging to be here in the middle of a pandemic for all of us, and I really appreciate that, and also appreciate our attendees today as well. So Sibel, so I'm just curious, I was just hearing your story about how you got interested in AI helping with your community practice. I think it's a great story. Can you tell us just a little bit about how you got started?
Yes, so we had been in the process of all the alternative payment model practice transformation. We were in OCM and trying to figure out one of our biggest problems was risk stratification, trying to predict the patient's illness ahead of time rather than from data that's been sent to us from OCM that goes back years before. We always acted on that data. Of course, we still use that, but in real time, we didn't have any alert, any risk stratification. So when our CEO, we are a member of Quality Cancer Care Alliance Network, which is a clinically integrated network for independent oncology practices throughout the nation. And we have a lot of good connections, very smart people. Our CEO heard it from another practice and brought the opportunity to us and said, "What do you think about this?" And I do work with our chief quality officer is my duo in doing all the practice transformation around alternative payment model and value-based care. And of course, we jumped at it because this is something that sounded extremely right in target for what we were trying to do, and it proved to be the case.
Yeah, well, it sounds like you became the local champion for leveraging the technology of artificial intelligence. So John, you and I have had many talks about all of this, and I think sometimes the clinicians actually just don't know how good some of the technology is in 2021 now. Particularly in the shadow of COVID, and I think that's been particularly useful. So tell us about the typical insights that one would get using the technology to improve the care for their patients, and also maybe a few examples.
Yeah, sure. So typical insights we're going to provide are both clinical and socioeconomic in terms of the nature of what's going on with a patient. We'll identify risks to individual patients for harm events, and we wrap that around an outcome that we're looking at or targeting. So let's take oncology, saying who's at risk for deterioration in the next 6 months, or who's at risk for severe pain in the next 30 days, or risk for mortality. And we'll provide those insights then to say these are the drivers for that event occurring. And then specifically, we are in the space what we call, what is called in the industry, prescriptive analytics. So we will provide insights into actions that can be taken, interventions that are either socioeconomic or that are clinical, that will change the outcome or improve the odds of changing the outcome for an individual patient. And I can tell stories, but a lot of them are Sibel's, so I would almost defer to her. There's, I'll give one example that is telling, and then she'll have many more, I'm sure. This was one of our other practices, and a patient was identified as at risk for mortality, who had, going back in my memory banks here a little bit, had a history of several cancers over the past 20 years. And this physician knew her very well, but he wasn't in that day. She came in presenting with back pain. And the mid-level that evaluated her diagnosed the back pain and some rash as zoster, and so began treatment for that. Turns out though that the sarcoma was recurring, and within 4 days she had progressive symptoms and paralysis as a result of the lesions in her spine, was admitted to the hospital, and ultimately declined and deteriorated and passed away. And this is tragic, but the question our physician colleague asks is, how did the Jvion insights it come to this conclusion? How did it know something we didn't know? And we don't always have the answer with artificial intelligence, but what we do know is that the ability to process thousands of pieces of data it brings machine learning to a conclusion faster and more accurately and holistically than when I, as a clinician, have dozens of data points that I'm trying to rationalize and say, what's the risk for my patient?
Sibel, do you have another example? Because that was a great example. You have another example off the top of your head about how this insight really made a difference for you in your caring of patients?
Well, my first case was a similar case where I couldn't understand why the patient died. That turned out maybe he had profound depression. That's what was the diagnosis in the clinic by my APP. But 4 days later, when he went to the ED and died, it was sepsis. And that was a patient who was improving with his cancer. Now, my couple cases I don't know how much time I have on this, but one was really impressive to me because I was actually going to COA meeting. I was going to talk about still Jvion at the time. It was newer for us. It was last year, April 2019. And on the plane, we have this list of 30-day mortality popping up in my email, and I see my list. And we have a system in place now, but at that time we were still putting that system in place. We were still perfecting it. And I saw the patient's name and I said, this patient had a CT 2 weeks before and had been doing great. Why is she, and I know her, she was doing actually fine. So I sent a message from the plane to my staff, bring this patient in, she needs to be seen. She's an old lady, so they brought her in. It was 4:30 and she lives alone, so she had to be brought by a caregiver, a family friend who went and picked her up. And in the clinic, they did draw blood, but she didn't look that sick. She was feeling tired and fatigued, and she said, I just don't want to do this anymore. And she never talks like that. So my APP was surprised. She was sent home after not finding anything clinically wrong. But by the time they went home, she collapsed, and her friend called and said, what do I do? And she ended up in the emergency room. We then changed the system. We're now looking if somebody's blood is worked on a situation like this. We do stat blood work so that we know the results before they go home. It turned out she had urosepsis and she was hospitalized and she was in acute renal failure. This was all new for her. And she turned it around. And that was pretty dramatic because I know that because she lives alone, because she's not very proactive, if her friend hadn't come and brought her, more than likely that day she would have died. So that was a very one of the greatest stories I have. But recently I had a patient who had finished early stage breast cancer patient who's finished her chemotherapy in August. By November, she's going through radiation, almost at the end of radiation therapy, comes in with very low blood counts out of the blue. There's nothing, no new medication. We brought her in, we couldn't understand why. And then she popped up I mean, at the same time, she showed up in our tool, and I said, this is not, something is going on. We couldn't figure it out, did some other additional blood work, said we would call her. We have a system where we actively call these patients, case management. On the third day, she came back with still low counts, and she was having diarrhea, and she hadn't been exposed to anyone who's diarrhea. I checked the COVID test, it was positive. So she had COVID from her daughter, and she was in the hospital for a long time. I mean, she declined very rapidly and died. And this was a 68-year-old healthy woman with who had finished chemo months prior. The only thing going for her was radiation. But that was pretty shocking to me. But it again alerts us that these patients need to be put in and seen immediately.
John, some clinicians are still kind of think that analytics like Jvion is sort of a checklist, automated checklist, but I think it's way beyond that. It's more like connecting the dots that a clinician is too busy or too distracted to really appreciate. How would you describe the technology behind Jvion in terms of connecting these dots?
Yeah, that's in 30 seconds or less, right, Anthony?
Yeah.
So
Without slides.
right. So if you take a universe of data, millions or billions of dots, if you will, and millions of patients, because our data universe has over 30 million patients in it. And so we're connecting thousands of dots about every single patient. I like the way you described that. We also connect the dots for those patients to outcomes.
Right.
Because we have the outcomes and stories on millions of patients. The machine learning understands the connection of the relationship and drivers between features about each individual patient and what's leading them into that outcome that we're trying to prevent. We can't do that. Our brains just don't have that processing capacity, for one. We can process simultaneously, the number is somewhere around 6 items simultaneously in our heads if we're really sharp that day. This is processing thousands of data points on
Right.
patients simultaneously.
Yeah.
That's in a nutshell.
The whole process is probably worse with the more and more electronic record pages that we have to see. So it's like we're increasing the noise without finding the signal. And I think the analytics is great for finding the signal for us.
There's so much noise. The other trap we fall into as clinicians is that this concept of heuristic decision making, where because I'm familiar with, I've seen this before, I'm going to come to conclusions quickly. And that introduces a lot of wrong decision making. It's a form of bias that it's similar to what I've seen before, and so it must be the same as what I've seen before. And that inherently colors our decision making. Machine learning, when it takes in millions of pieces of data, cleans the slate on some of those inherent biases that we're concerned about, especially when it comes to social determinant factors and features that are driving risk.
Yeah, it's like having a data scientist as your partner when you go through clinical practice. So Sibel, tell us how your practice is different now with learning how to use the analytic tools versus like before when you weren't taking advantage of that. How does your day-to-day practice different now? You mentioned real time, which I think is a really key phrase, but how is it different otherwise?
When it comes to just Jvion, how it changed our practice, we had to make some operational decisions to provide the additional support we needed to, when we get the data, what do we do with this? First was, of course, we have palliative care consults, and we have a palliative care system in place with the APPs. First, not just doing them on a regular basis and whatever time they need to have a palliative care consult, but these alerts make some of these patients come in earlier and scheduled in a more timely manner to assess for the need of palliative care. That could end up being a better pain management or better depression management, but that has significantly changed, and we really lacked in that end of life or palliative care area in the past, but this really helped us to pick up our numbers to the positive way and provide better patient care. But one of the major things that happened is the creation of acute care clinics during the weekdays. We had one on the weekends, and we staffed it with the physicians and the APPs on a rotational basis, but we actually decided to hire 2 APPs for two major clinics and turn daily ACC them into ACC clinics. And that came because we realized we have enough patients showing up in Jvion. We have enough patients that need to be brought into the clinic out of their normal schedules, and doctors are busy. And besides, these patients, when they show up in the list, it's not a quick visit. It takes time, either identifying a real illness like sepsis or something that's mysterious, but something is going on. And maybe it is false, but something is going on in that patient. Just pay attention. Don't get fooled by the good-looking patient, because labs will be abnormal or something. And then the other is the palliative care. If you get into palliative care discussions, those take too long, and then ACC clinics provide that additional support. So my clinic, and that what it did, it improved the care. I'm sure it did, because we saw several examples of that, but it also increased the patient satisfaction with its surveys, and patients appreciated to be called into the clinic and brought in, hey, doctor would like to see you. They have a good messaging. It's not alerting, it's not scaring, but at the end, when it's explained, patients do appreciate it very much.
Yeah, no, I think that it's a great message that we sometimes are just not truly aware of our sickest patients. And I sometimes some of my colleagues would say, you know, bring your best AI tool, and we still think human doctors are better. I think that's less and less as a rhetoric, but it's still out there, right? So some clinicians are, and rightfully, you know, want to have 100% ownership, and it's hard for them to lose. They feel like they lose a little bit of their autonomy with the analytic tools. In fact, I think it increases their autonomy, because you're free to have creative thinking. You still ultimately make the decision. So I think the mindset is changing, but it's still, right, John, it's still sometimes pretty slow that human clinicians have either hubris or just not willing to let go of the autonomy and feel like these analytic tools they're a little bit intimidated in terms of, I think it's because they know how good they are sometimes. They're a little bit afraid to be frail in front of the tools. At least that's still what I'm hearing. Do you still hear that, John, out there, that clinicians are a little bit afraid to let go?
Yeah, and it's resistance in a variety of ways. But I mean, look how slowly the medical profession changes. I'll quote this example. You've probably heard me mention it before, Anthony. The National Heart, Lung, and Blood Institute back in 1983 instituted a study looking at the impact of beta blockers for reducing death in patients who had a heart attack in the hospital. And a 37% reduction was compelling. They cut the study short. This is a standard of practice. Then the cardiology guidelines came into play, and standards were established, and that got compliance with that guideline in the next decade to somewhere around 25 or 30%. It took 25 years before it was instantiated as a core measure, and then ultimately retired in 2008. 25 years for us to change practice around one life-saving behavior.
Yeah.
So evidence-based care came in the late 90s, and we had these same conversations that I don't practice cookbook medicine. And then we realized that care guidelines and pathways are enabling. It allows me to think about what I need to be thinking about. AI is going to do the same thing, but it feels much the same, I think, viscerally to physicians as when they were reacting to that. And this is the next step in iteration and us getting better as clinicians, I think.
I think part of the equation, though, John and Sibel, is that we've had free license to practice any way we want for a very long time without extreme scrutiny, you know? And I think that's maybe that's part of the advantage of being a clinician. You do have that range of practice. On the other hand, it's not necessarily leading to the best outcomes, right? So we don't want to admit that, but it's true. So Sibel, how about, what do you say to clinicians that say, you know what, I know my patients best. I know who's the sickest at any given time in my practice, and I don't really need this level of, you know, support from the analytic tools. How do you coerce them, or what do you recommend to them?
Yeah, I think I don't understand, maybe because I forgot, maybe I used to think that way, but I don't anymore since I'm doing it and I see the benefits. I don't think the artificial intelligence tool as oh my gosh, my job is in jeopardy, and it's gonna do something that I didn't recognize, and it's gonna make me feel bad. I see it as a complementary thing. It just enhanced my patient care. I mean, what do we at the end of the day want is good patient care. We all care about, there's no doctor out there, I mean, in oncology world, people are so dedicated taking care of their patients. They are possessive. That's one of the reasons this, I think, notion comes around. But if the patient care is going to be better. Why wouldn't I be using this tool? I think John's example of clinical pathways is a good example.
Yeah.
What about EMRs? I remember the days we used to write on a piece of paper and things would get lost. I remember when I first started my practice, I saw someone scribbling some chemotherapy doses on a piece of paper and giving it to the nurse. I'm thinking, oh my gosh, I did practice in those days. We would never even think about this right now because it's not good quality. It's bound to mistakes, and I'm sure people got wrong chemotherapy doses because of that. It's the same thing. This is just another tool, and not just another tool. It's a great tool for me as a clinician to be alerted. I am still doing my job. I'm still being the doctor. I still see that patient and evaluate and make the decisions. The machine doesn't tell me what the diagnosis is. It's telling me something wrong. You'd better take a look at this patient.
Yeah. No, this reminds me, John, you appreciate this little story. Well, when we were traveling last year, I was in New York City and I got into a cab, and it's one of those old time New York City cab drivers. And he said to me, you're lucky, I'm one of the best cab drivers in New York City. I said, how do you mean? I can get you anywhere in New York City the fastest, the most efficient way, and I never have to look at a map. And he's like in his 60s, I'm sure he's right. But the thing is, why would you insist on doing that and not use a GPS with a traffic pattern, right? Because that actually is difficult to beat as a human being. And why do you have to be so stubborn about not using a GPS? So that's how I look at tools like Jvion. It's like a nice GPS. You don't have to use it, but it's awfully nice to have it, especially with a traffic pattern built in, which is kind of analogous to real-time analogy of having this information available, because oftentimes we don't have that information real time, right? So but I think there's still a lot of education, like with these webinars. I think just have people realize they should just try it, and once you try it, more likely than not you're going to find that it's extremely useful to have, and it'd be hard to do without after a while. So in your journeys, John and Sibel, maybe Sibel first, so what are the lessons learned along the way, especially with adoption, and how are you approaching that, and what would you do differently compared to a few years ago before you started using it?
Yeah, I think what I would do differently today is maybe we are not extremely big. We don't have layers of bureaucracy. We have several different locations, so we're spread out, and communication in person is very difficult. But we still communicate well. But I think dedicated training for physicians and other APPs is extremely important, because we communicate with big meetings. Hey, this is going to be happening. This is what's coming, and we give a little bit of synopsis of the tool and what is being done. And of course, partners still have to make decisions on hiring ACC, APPs kind of thing. But dedicated time, really one-on-one, because everybody's technology understanding and learning curve is different. And if people can understand what's the background of this and all these things we're talking about, there is no big, I didn't encounter, like my colleagues in other practices, that physicians looking at it with big doubt and big paranoia, but still, I mean, pretty removed from all of this. I think bringing them into more education, probably what I would have done differently. I think our administrator who put this in together has done an amazing job. She assigned people to this, and they learned it deeply, so that they can deal with any glitches if there is any, or communication piece. But I think maybe I should have done that better with the physicians. I would really recommend to bring all the providers into the learning curve as quickly as possible.
Okay, John, you've been at this for a while now, any lessons learned, and how things change? Are things changing out there when you talk to so many clinicians about all of this?
Yeah, well, I got to confess, I thought that the transition to adopting AI would be much faster than it is, and I've had to do a gut check as to why is that. You've implemented, I've implemented EHRs, and that's almost simpler because it is so defined, and you're forcing a change in behavior and activities and actions, and you just do it. When it comes to this, it's changing decision making. And deploying decision making or clinical decision support is always more optional. It requires an internalization of thinking that is not the same as change management for an EHR. So that to me is one of the biggest differences, and realizing that requires different skills in those that are driving the change. It requires leadership, and Sibel and Amy there at Northwest have epitomized that leadership. So that's one of the learnings. The other learning I would say is I'll recognize it's a journey, and that requires being patient, and you take it in steps. And Sibel has indicated along the way, but if you put our story together, they've evolved, and they're amazing in their practice and how they continue to evolve and incorporate the use of AI into their practice.
Yeah.
So treat it like a journey rather than as a point in time and we're just changing it and then we're done.
Yeah.
What I've seen in the industry and in the market, there is a receptivity, at least in the healthcare culture, and part of that is provoked by COVID to say we need to do something different. And there's more openness to doing things radically different than there was, 2-3 years ago. So I have hope for the future.
Yeah. No, I think it's actually a great time right now, because as people are saying, it took a pandemic for us to kind of wake up and see a lot of the inadequacies in healthcare, particularly in dealing with data and using analytic tools. So I do think there is a significant movement to be willing to share data, right? Sibel, wouldn't it be wonderful if you have access to everyone's oncology patients' data, right? I mean, to make decisions. And that, I think we'll see that in our lifetime. But how we get there, I think, as you pointed out, is going to take a lot of education, a lot of, as much as we think we're individuals in clinical practice, we do tend to have some groupthink, right? So if a few clinicians are doing something cool and different and showing improved outcome, then that's going to really accelerate adoption. And I think we're starting to gather the list of clinicians that are willing to try it and have shown that they have improved patient outcomes. So any tips on people that are just like, okay, I want to give it a shot. How do they just get this started? Maybe we'll start with Sibel again. How would you, like, and I always say just jump in and do something. Learn about something, learn about analytic tools, do a small project, just jump in. You don't have to wait. As I say, you don't have to wait and get permission from anyone. But what would you say to people that are like, okay, you got me convinced, I want to give it a shot. What would you say to get started?
After jumping in, for sure, identify that team. You need a physician lead, and you need someone who's an administrator that understands the flow of the whole organization. And maybe they can identify a task force. I mean, every practice is different. What we learned from our experience with others as well, the workflows, if you put them on a little map, all look very different. But then those two people with their teams developing around them will be able to put this in actually very fast. We had about 1 month to 2 months, our administrators sat down and made sure that it had a validity with our EMR data, and then started and dedicated a person living in the machine every day, looking at the data every day. So and from there we put the system together. It takes a little time, a little work. But you know what? We've done a lot of changes. I think EMR was much more difficult and took much more effort than Jvion tool. So I think it is easy once you identify
Right.
who's that
more
team.
about cultural transformation than the technology. John, on the last minute here, someone mentioned that they still believe in the power of history and physical exam and touch, which I think which AI cannot do. We totally recognize that, right, John? I mean, the AI is going to add to our practice, not take anything away. And we don't want to just do analytics for our practice. But I can tell you, as a recent patient, there was not a whole lot of history and physical exam because people are so distracted by everything else they have to do, and hopefully analytics can actually decrease their burden, right, in terms of electronic record.
That's right. The art of the clinical exam and the art of medicine is through the history and physical. It's very important to do that. But what our insights do is bring a little bit sharper focus and faster. We have an example where case managers, they cut their 45-minute interviews down to 15 minutes. because they're targeting and bringing focus to the
I argue
questions.
you actually have more time to enjoy the social and the physical exam and all of that, because you're not going to be as burdened with the stress of electronic record and connecting the dots on your own. You have a partner trying to help you connect the dots as well.
That's
So
right,
with
teaming
that,
it
I
up
want
for
to, yeah, Sibel and John, thank you so much for spending some time with us during a very busy pandemic period. I hope both of you stay healthy and well, and we're also going to, in some way, bring all of this back to our AI Med clinician series in the third quarter, which is going to focus on oncology and primary care and everything that we just talked about on September 28th and 29th. So we'll hope to see you there. Bye, everybody.
Excellent. Thank you.
Bye-bye.